And welcome to another edition of the Osteopathic Lyceum podcast. We're going to walk through the concept that I'll call hierarchy, or essentially what you would put at the top of your hierarchy, and why that is going to matter for many of the things that I've said in the past with respect to how osteopathy has a challenge with all of the subdivided components within it, or the subdivided system, whether you want to speak about cranial, visceral, fluid-based treatments, things like energy work, whatever you want to talk about. I have made the claim in the past that most of those things are essentially the same as one another, because if you look at how osteopathy is actually performed, it is within the physical realm. It is one person interfacing physically with another person. You have to have an assessment. You have to then have a physical intervention that is going to work on the motion finding of that assessment, and then you need to reassess, at least if you're going to be honest with respect to what you claim you found and what you claim changed on the physical level. What is going to become a little bit more apparent is that the primary difference with respect to treatment, or really interpretation rather, of physical findings is what is at the top of the hierarchy. So if you use the terms of the philosophy of science, we're making an axiological, or we're having an axiological discussion, axiology being the values or the value judgments, at least within research of the researchers. Within any other activity, it would be the value or value judgments of those engaging in whatever that activity is. So with respect to osteopathy, when you want to speak about your interpretations of your physical findings, now, let's just say you find a problem with the motion of the right shoulder for some reason, right? So the right shoulder is not moving as much as it could, especially when compared to the left shoulder. Let's just say you have visceral concepts at the top of your hierarchy. You're going to say it's most likely a problem with the gallbladder embryologically, because they're related, right? There is some stable referral pattern of gallbladder pain to the right shoulder. Now, it's not everybody who has gallbladder pain will also have some challenge with the right shoulder, but there is at least some connection there. So if you want to make that interpretation and visceral concepts are at the top of your interpretation, then it's clearly an embryological issue relating the gallbladder and the right shoulder. If you want to make a if cranial concepts are at the top of your hierarchy, then clearly the reason that there's a problem with the right shoulder is the cerebrospinous fluid is not moving appropriately, and it's not flowing appropriately. Therefore, we have a knock-on effect or a related effect through the nervous system that is all about dural tension, cerebrospinous fluid. Therefore, if we correct the dural tension, the cerebrospinous fluid, the shoulder should be functioning more appropriately. If you're more of a structural practitioner, then there is likely something going on closer in proximity to the shoulder itself, some neuromuscular or soft tissue connection, right? You can see how the interpretation of the same finding is going to be indicative of the values or the value judgments of those involved. Now, what I want to make as clear as possible is that the people making these claims are not absolutely the ones who made these value judgments or created these hierarchies of interpretation. It's entirely possible that what happened was whoever the first person in the line of this interpretation would be, whatever the system may be. If you want to talk about cranial, you could be talking about Sutherland. You could prefer the Roland Becker model. You could prefer the Upledger model, so cranial sacral. If you're talking about visceral, you probably are in current times thinking about Barral, but you could be thinking about other osteopathic practitioners earlier and interpreting in the way that they do. But what you're doing to at least some degree is you're offloading the interpretation that was handed down culturally. It was not necessarily handed down through appropriate observation and experimentation. It was handed down through cultural processes. So these cultural processes then are inculcating the details with which a given practitioner will think. So thinking is dependent on details. If you are culturally associated with somebody who prefers visceral approaches, then those are the details you're most likely to put at the top of your hierarchy. Therefore, regardless of your finding, you're going to put it through that lens. That is not a strange thing. but it can have major issues, especially with respect to how you're going to interface with your patient, because you're going to tell your patient the story that you believe is accurate. Your story is probably wrong. If you're in osteopathy and you're doing, and you're providing a mechanistic explanation that is anything other than, I have identified that this thing is not moving as freely as it could or as freely as its paired structure, and aside from obvious trauma, we're not 100% sure why, but we do have a way to interface with our finding that is provides a relatively stable range of results. If you're doing something other than that, you're almost always making a mistake. And if you're not making a mistake, it's an accident. It's just a complete luck of the draw that you might be correct. So the discussions that are often had within the profession that I am obviously holding a negative view towards are the ones that are really much more describing cultural transmission of concepts that people will place at the top of their hierarchy. Now, people could use the term cognitive bias, right? Now, what I would say, and I've said this in other places, if you should choose to look back at things that I've said in the past, the cognitive biases are really collectively just fancy descriptions of mistakes in thinking that the person who's doing the thinking doesn't know they're making, right? Now, you could argue that, let's just say today, in today's world, somebody who's following a Sutherland cranial approach is less active in that choice. So it could be a bias. It could be a mistaken thinking that they don't know they're making. That is possible. But with available information and people maybe using a confirmatory approach to information, you can then call that confirmatory approach confirmation bias. So they would look through available literature and find the things that seem to support, and then that's a mistaken thinking that they don't know they're making. But they're also showing an obvious preference, which is a little bit more active for the thing that they've placed at the top of their hierarchy. So if somebody's following cranial Sutherland concepts today, it's probably cultural transmission that got them there. It's probably a lack of alternate details that keeps them there. When presented with alternate details, that the interpretation of findings related to the cranial or the Sutherland cranial approach being just flat out incorrect in observable reality, if they choose to stay with the Sutherland interpretation at that point, then that is a preference. That is less of a bias because it's a more active choice. So there are essentially active and passive choices that have occurred within the profession of osteopathy that have allowed for cultural transmission of concepts over time. What I'm suggesting is that the place you can see that, or the way you can describe that, is either with the term hierarchy. So they put a particular interpretation at the top of their hierarchy and they use it constantly. Or you could say axiological. Axiological, or a value judgment, an axiological approach or process, is a little bit more active than passive. So those who follow a cranial Sutherland approach because that's all they ever learned, it's probably more passive and normal cultural transmission phenomenon. Whereas if they are aware of multiple approaches, which most osteopathic schools will provide information on, which is most common. So in most osteopathic education, you will learn about visceral concepts, you will learn about cranial concepts, you will learn about structural concepts, you'll learn about energy concepts, you'll learn about neurological concepts or neurological approaches. You'll learn about all of these things. What will often happen at that point is people will zero in on the one that they find the most valuable. So they will make more of an active choice as to what to zero in on, and then that's their preference, and they will go along, and then they will become part of that cultural transmission process. So the reason I have a stronger challenge with that than maybe others in the profession do is that osteopathy is, as much as anything would have a culture, and osteopathy is going to have its own culture, I think the culture is inappropriate for the actual needs of the profession. The profession is fundamentally performed in a positivist way, or in a way where there is a shared reality that has variability, and you have to respond to that shared reality. So because you have more than one person, you generally have a practitioner and whomsoever is presenting themselves for some form of treatment, assessment and treatment rather, there are a minimum of two people involved. Therefore, the reality must be shared. And you need to be more in that physical realm, because the realm of performance for osteopathy is the external realm of observation. So you are outside the patient, but it is physical in its nature. You must physically assess motion. So regardless of which system you look at, all of the tests are a physical assessment of motion. You have lots of discussion, you have lots of talking, asking the patient lots of questions to gather information to maybe essentially guide where you're more likely or where you feel you're more likely to find things. But the talking and the gathering of information has less bearing on treatment than the physical movement findings. The physical movement findings are the thing that dictates any form of treatment. The response to whatever treatment is chosen is what guides alterations in how that treatment is applied, because what you're looking for is specific types of outcomes when you apply some form of treatment to the patient, right? So you're looking for the tissue to increase tension without the patient saying ouch, or you're looking to remove tension from the tissue, right? To remove conceptually sensory information, right? You're trying to reduce sensory information in the region conceptually. Whether that's what's happening or not is up for discussion, but it's a physical performance. It's in the physical realm. It is a shared reality. So when you have an idea at the top of your hierarchy that essentially guides how you will interpret, what you are doing less of is paying attention to the immediate physical reality that you are sharing with somebody else. You're paying more attention to whatever idea is at the top of your hierarchy, because that right shoulder restriction could be interpreted as a gallbladder problem. So that dictates that you're going to then look at essentially, I believe, T5 to T9-ish. You're going to then look at the ribs on the right. You're going to look at the vertebral column close to there. You're going to ignore, if you don't find anything in those areas, then it's probably a shoulder problem, because clearly visceral is the thing that's at the top of my hierarchy. So there has to be a visceral component. So I'm going to apply treatment to the area that I assume something exists, even if I don't have the physical finding, because clearly it's the gallbladder, right? Or the gallbladder has to be involved somehow because it's right shoulder pain. So what you can do with whatever you put at the top of your hierarchy is remove yourself because of an idea that is governing how you interpret from the situation at hand. In doing that, you are ignoring the actual consistent, stable reality under which osteopathy is performed. It is a shared reality between a minimum of two people, and it is physical from the external realm of observation. So whatever you put at the top of your hierarchy, because let's just say you're an osteopathic practitioner, there are going to be times where there is some form of internal process that is generating some of the complaint that your patient has. You're going to have some way to figure that out. But if you think that there is always an internal process, then you're not going to figure out when there isn't. So you can be blinded by whatever's at the top of your hierarchy. So my argument would be that there may be a multitude of processes, there may be a multitude of things that can generate the dysfunction. The way that osteopathy is taught, it is fundamentally taught, or at least in standard textbooks, that it is a philosophy. And philosophy is defined essentially as thinking that does not require evidence to come to appropriate conclusions. This is in osteopathic textbooks. You can go back through things that I've shown before, and you can find that. I believe it's Foundations of Osteopathic Foundations of Osteopathy. There's part that's in there, and there's part that's in a different book, which I do not remember. I believe it's an osteopathic approach to diagnosis and treatment. I'm not 100% sure. I don't remember off the top of my head right now, but you can find these. You can track these things down. Osteopathy is taught as a philosophy. The 5 models of osteopathy, I've discussed this before. The 5 models are interpretive steps. There's a neurological model, the circulatory model, right? There's these different models. They're interpretive models. They don't tell you what you found. They give you an opportunity to interpret what you found. What I would say is that if you stay in the realm of shared reality between you and at least the person who's presenting for the assessment and treatment, so you, the practitioner, and the person who's presenting for assessment and treatment, and you stick to the things that is stable amongst all subdivided osteopathic systems, which is motion findings, and then approaches to interfacing with those restricted motions that provide a stable range of results. And whichever way you choose to provide the interface first, depending on the response that you get, you alter. And then you reassess. And if that motion has changed in an identifiable way, then you've done your job. This is where the concept from Dr. Still, or that is attributed to Dr. Still, find it, fix it, and leave it alone, and nature will kindly take care of the rest. You are working in that shared physical realm. You are finding motion problems. You're interfacing with motion problems in a stable and reliable way. You are tuning into the patient and how they respond, and you are figuring out if those motions changed. If those motions changed, that's where nature will kindly take care of the rest, if it can. This is how this all ties together, as opposed to saying, whatever my finding is, I'm doing cranial. Whatever my finding is, I'm doing neurological. Whatever my finding is, I'm doing fascial. Whatever my finding is, I'm doing uh, a fluid-based approach. If you put something at the top of that hierarchy, it is going to preferentially guide your interpretation, and it will preferentially take you away from what is directly in front of you. So if I was to make a suggestion as somebody who cares about the profession, walk away from all of these subdivided systems, walk away from the 5 models if you dare, because it is an interpretive step that really gets in the way of actually providing appropriate patient care in the moment. Patient care is highly individual, and it is highly in the shared reality. So you can't take an overarching idea that could be called a group idea. You could call cranial, you could call visceral, you could call fluid-based approaches. You could call all of these group ideas because there's a shared concept that lives within the minds of the many that practice it. If you apply that ideology, you're subservient to the group. You're subservient to the idea. What you should be paying attention to is not the group, is not the idea. It's the individual who's in front of you. Osteopathy has a very, very fantastic way of doing this. Motion-based assessment, application of treatment that generates the desired short-term outcome during the treatment. So either the tension goes up without the patient saying ouch, or you remove tension from the area so the patient doesn't say ouch. Then reassessment with the same initial tests that you did to identify whether or not it had the intended outcome of changing motion. That is an exceptionally powerful thing because it has a lot of attentiveness to the situation that is right in front of you, as opposed to walking down the road of being subservient to a previously existing idea that has knowable flaws at every level. So all of these osteopathic systems have flaws at every level. If you zoom out to that more macro position of, I can identify motion problems, I can interface with motion problems, I can change motion problems, and then nature will kindly take care of the rest. You're being a little bit more accurate to both what you can find, what you can do, and what will actually benefit the patient, if it can, because there will be times when the patient's complaint has no meaningful connection to mechanical findings. So once again, if we use the concept of hierarchy, we better highlight the problems that I've attempted to articulate across time better, maybe, than I have before. And once again, I will essentially end with that most, especially within the educational sphere, within osteopathy, most of these concepts can suck salt and kick rocks, whether it's cranial, visceral, fluid, doesn't matter. They are predetermined explanations that normalize in a way that is probably inappropriate. So you become involved in a cultural process, a transmission of a knowably incorrect idea that you become subservient to. So please stay away from that if you can. I understand that there is the argument that these common stories that are passed down culturally through educational institutions allow for consistent repetition of results between practitioner and patient. But I would say that it doesn't need to be that way because there's a much more digestible, much more honest approach, which is the one that I've outlined. Motion assessment, treatment that is appropriate to the motion findings, and if it isn't in the intermediate term, adding tension without making the patient say ouch or removing tension from the area, whatever you choose to do, and then reassessing with the initial test. If it's something outside of that, it's just superfluous. It's extra. It's not required. It doesn't guide behavior any better than that will. That's the framework that you need. That's the framework I suggest that people continue to use. And if you have listened this far, I thank you greatly, and I will speak to you again. I will continue to try to articulate this as well as I can across time. I will continue to attempt to reach out to people who will bring you interesting ideas that will help you understand the profession that you're engaged in, maybe at a different level than you currently do. So thank you, and we'll talk again soon.